from Australia, Dr. Kiran Sekhar was the faculty speaker. So we are trying to rope in the world for the Nephro Critical Care Society. So the event is being recorded, so I think we should be respecting the time for everyone. And anyway, this would be available in our Nephro Critical Care YouTube channel as well as our website in subsequent, maybe in the next upcoming 1 day or 2 day. So if everything is okay, Dr. Jacob, if you permit me, I can start the proceeding without further delay. Dr. Murugan, should I start or I should wait for 1 or 2 minutes, whatever you say?
I think we can start since it's already 2 minutes over. So in the interest of...
exactly. Yes, exactly. So very good evening, good morning, good afternoon, as we have the attendees from all over the world. So dear esteemed colleagues, on behalf of Nephro Critical Care Society, I extend a warm welcome to Lifeline Nephro Critical Care Webinar Series 5. As the General Secretary, I am thrilled to announce this truly global event because today we have speakers, faculties from all over the world, and it is definitely going to be an extensive knowledge dissemination on two important topics that we always struggle at the bedside in nephrocritical care. One is volume management in acute kidney injury patients, and the second one is peripartum AKI. So let's embrace this opportunity today to learn from the doyens in nephrocritical care. And for this, the event to proceed, I have my colleague, Dr. Jacob George from Kottayam, and he is also the organizing chairman of the nephrocritical care review course, which is being scheduled on 27th and 28th of April. So only 3 days to go. Now with me as well, our young dynamic intensivist from Lucknow, India, Dr. Suhail Sarwar Siddiqui. He is the quiz master who would be conducting the quiz online after end of the two talks. And I would be also taking the opportunity to welcome the panelists first. And yes, it's a truly global event, as I have told. So the panelist for today is Dr. Jigar Srimali. He is the consultant nephrologist and transplant physician at Renal Kidney Hospitals, Ahmedabad, India. And he is also the author of textbook of dialysis therapy. We have as well Dr. Sananta Kumar Das. He is the consultant intensivist from Townsville University and senior lecturer at JCU School of Medicine and Dentistry. And he's as well the academic secretary of Nephro Critical Care Society, and he's from Australia. And last but not the least, we have Dr. W.D. Dilsan Priyankara, very dear colleague and friend, consultant intensivist, president of Ceylon College of Critical Care Specialist, National Hospital of Sri Lanka. So definitely with their experience as well as expertise, we would have a good panel discussion at the end of the first one as well as the second one. Now, the moment has come when I have the honor to introduce none other than Professor Dr. Raghavan Murugan, and he is the Professor Critical Care Medicine and Clinical and Translational Science, Chief of Critical Care Medicine at UPMC Maggie Women's Hospital, and he is as well the Director of Program for Critical Care Nephrology at University of Pittsburgh School of Medicine. So he doesn't require any introduction. Whoever has keen interest in the nephrocritical care, and I had the honor of meeting him as well at Hyderabad, India recently during the AKI CRRT San Diego conference. So welcome, sir, to our nephrocritical care webinar. Now, I also welcome the power packed, I would say the powerhouse, Professor Dr. Safa Hilal. She is the professor anesthesiology, ICU and pain management at Menufia University, Egypt, and she is also the founder and general manager of Egyptian Society of Anesthesia and Critical Care. So believe me, today we have I would say the battery, which would be getting us charged continuously with the power packed webinar, which is coming up. And to facilitate with me, I also right now invite Dr. Jacob. Dr. Jacob, if you want to share something, or else I would request the first speaker, Dr. Raghavan Murugan sir, to start his talk.
Thank you, Dr. Sahu. Good morning, good evening, good afternoon, everyone, depending upon wherever in the world you are. So it's really my honor to speak at this meeting. So this is the first meeting, and I'm fascinated by the organization of this group to be able to conduct these regular seminars and education for our trainees. And it's really my honor and privilege to be speaking with you today. So with that, I'll get started. So Dr. Sahu, can I share my screen?
Yes, sir, please.
Okay. So what I thought I will do is provide everybody with an overview of some of the emerging sort of evidence on ultrafiltration and fluid management in critically ill patients requiring CRRT, with a specific focus on net ultrafiltration during CRRT for managing fluid overload in critically ill patients. So in terms of my disclosure, I have received grants from the National Institute of Health in the US, specifically the NIDDK, to conduct a randomized trial of fluid management in critically ill patients with acute kidney injury. I've also received funding from industry sources to conduct the research. However, whatever I'm going to be talking with you today does not conflict with any of the industry funding. So primarily the work that I will be sharing with you today are funded by the National Institute of Health. So I'd like to get started with this case presentation. I think everyone who works in critical care is pretty much familiar with this kind of patient. So this is a 36-year-old female patient who I took care of at McGee Women's Hospital a few years ago. She's had mitral valve replacement, hypertension, admitted with severe COVID pneumonia and ARDS. She was prone ventilated with severe hypoxemia, with a PF ratio less than 100, PEEP of greater than 20 centimeters of water. She developed AKI, creatinine went up to 5.9, urine sediment revealed muddy brown cast. We tried to use bumetanide infusion for volume control, but however, she was not responding and continued to remain anuric. She was also severely hypotensive, requiring norepinephrine infusion at 0.1 mics per kilogram per minute. Her pulse pressure variation was 8%, and she was 10 liters positive since admission. And this is a chest X-ray. As you could see, she's got extensive bilateral consolidation on the X-ray, as well as fluid overload, as you can see. We've already placed a dialysis catheter in the anticipation based on the anticipation of kidney replacement therapy, based on the labs. As you can see, she's getting hyperkalemic, she's acidotic, and essentially completely, hyperphosphatemic and so on. So we with a plan to start her on CRRT and continue, managing both the solute clearance as well as volume clearance. For this talk, I'm just going to focus only on volume management because this is the sort of the elephant in the room. So if you think about fluid overload, it is a big deal in critically ill patients. And increasingly, evidence shows that, positive fluid balance is highly prevalent in critically ill patients, and it is associated with mortality. So this is a study that we conducted a few years ago, along with my fellow here at the University of Pittsburgh, looking at the UPMC data set of over 18,000 patients, where we, analyzed the data set for the number of patients who had fluid overload. So we calculated the cumulative fluid balance, which is essentially using this formula here, daily input minus output divided by hospital admission weight. And we multiplied that by 100 to determine the percentage of fluid overload. And then we stratified them based on less than 0%, 0 to 5%, and greater than 5% fluid overload as negative, even, and fluid and positive fluid balance. As you can see here, among patients who continue to have greater than 5% positive fluid balance, there's a significantly increased risk of hospital mortality. Furthermore, when you follow these patients up to 1 year after critical illness, you can see that positive fluid overload is significantly associated with a substantial increased risk of death when you compare it to patients who have even fluid balance or negative fluid balance. Furthermore, and this is after adjusting for all other risk factors in critically ill patients, including age, severity of illness, mechanical ventilation, disease process, etc. And furthermore, this risk of death associated with fluid balance is not constant over time. It varies over time, but nevertheless, it persists up to 1 year. So the risk is much, much higher. Immediately after ICU admission, after that, the risk continues to vary, but nevertheless persistent over a 1 year period of time. So when you look at patients with positive fluid balance, among those who receive kidney replacement therapy, nearly 75% of the AKI patients who are treated with kidney replacement therapy have fluid overload. And every study actually shows when you have fluid overload in this population, the mortality exceeds more than 40%. And some studies report up to 60 to 80% risk of death. And if you look at these patients, you can identify these patients pretty much earlier on. Within the first 24 to 72 hours of ICU admission, these patients receive substantially higher amount of fluid. In this study, using the UPMC dataset, you can see that they were 5 liters positive within the first 24 hours. And then within the 72 hours, they were 7 liters positive. And within a week, they were almost 10 liters positive. So primarily, we use net ultrafiltration, which is net fluid removal by clinicians to treat fluid overload among these patients. And this is supported by KDIGO guidelines and also the Acute Dialysis Quality Initiative guidelines based on observational studies. So just to let everybody know, there is no randomized controlled trial that, to my knowledge, that have been conducted to see whether fluid overload, fluid removal in critically ill patients is associated with better survival. Most of the evidence that we have are just from observational studies. So, and one such observational study is this trial, which is a post-hoc analysis of the renal trial that was conducted, I believe, in 2009 when it was completed. In this trial, when they went back and analyzed patients who were, according to their fluid balance, survivors, tend to have an approximately a negative fluid balance of 500 mLs every single day during the course of an ICU illness. Whereas non-survivors, they tend to remain positive fluid balance. And based on this and many other observational studies, people have concluded that fluid removal or ability to keep the patient in a negative fluid balance is associated with better survival. So we all use it in the hope that it will improve the outcome of our patients. Nevertheless, there is no strong evidence from randomized clinical trial. And importantly, patients who do better from fluid removal and negative fluid balance, it may be that it's got nothing to do with fluid removal. It's got everything to do with the physiology that allows you to remove fluid. So in other words, it's not the fluid removal that might be driving the outcomes, but it's the homeostasis and the physiologic condition that allows you to remove fluid that is associated with better survival in these patients. The only way to prove that is to conduct a randomized trial. So having said that, we all use fluid removal in the ICU, net ultrafiltration. However, how do we do that fluid removal is not specified in any of the guidelines. So we know, for example, when we dose solute clearance in critically ill patients, we do know that if you're using CRRT, an optimal dose is 20 to 25 ml per kilogram per hour. We do know from randomized trial that the higher dosing is not associated with better survival. But we do know that lower than that is associated with, lower than 20 ml per kilogram per hour is associated with poor solute clearance and increase in the hazard of risk of death. However, nothing of that sort exists for how we should dose fluid removal among critically ill patients receiving KRRT. And if you actually think about it, both slower and faster net ultrafiltration rates have risks and benefits. If we do it really, really slow and we don't remove fluid at all, then there is a risk of organ edema, right? So we all know that patients develop hypertension, they are difficult to wean from the ventilator, they have poor renal recovery and so on. On the other hand, if we remove fluid really, really faster, there is, hypotension, and there is evidence to show that these patients have cardiac arrhythmias and cardiac stunning and decreased organ perfusion. So both organ edema and organ ischemia can lead to organ dysfunction, both of which is likely to increase the risk of death. So I was interested in this, and we wanted to study this. So in a series of studies, we went to examine the relationship between the net ultrafiltration rate and outcome. So this is the data using the University of Pittsburgh ICUs, where we looked at both CRRT and IHT, trying to understand, can we get some idea on what is the optimal dose that we should be using to improve outcomes? In other words, how much we should be removing on any given day to show that it's associated with better outcomes. So we classify the net ultrafiltration rate as the sort of the net volume removed divided by the weight and duration of renal replacement therapy in days, and we stratified it based on, and the unit of measurement is ml per kilogram per day. And we stratified the relationship between net ultrafiltration rate and 1-year mortality. And you can see this J-shaped relationship where lower than 20 ml per kilogram per day is associated with, increase in hospital mortality. And if you increase it up to greater than, 20 ml per 25 ml per kilogram per day, was associated with, somewhat of a lower mortality. So there is this, and the lowest mortality was those who received anywhere between 20 to 25 ml per kilogram per day. So that works out to be somewhere around, 1 to 1.5 ml per kilogram per hour if you're dosing it based on CRRT. And so this is what we found was the higher the intensity in this study was associated with better outcome. So the more you remove, the better the outcome was, as long as you stayed around like 25 ml per kilogram per day. And this is after adjusting for all the risk factors in critically ill patients. So we then subsequently went to so this is a single center study only in UPMC ICUs. And then we wanted to replicate this finding in CRRT alone patients and in a multi-center study. So we went and collaborated with Ronaldo Bellomo from Australia, looking at the renal trial data set, which is a trial that was conducted in 2009, comparing 2 different intensities of solute clearance on CRRT. So using that data set, we looked at the relationship between net ultrafiltration rate on an hourly basis and 90-day mortality. And we classified the net ultrafiltration rate as a cumulative net fluid removal divided by study enrollment times treatment duration. And we stratified them based on less than 1.01 ml per kilogram per hour, a dose between 1.01 to 1.75, and then the higher tertile is greater than 1.75 ml per kilogram per hour. So this stratification was essentially based on the tertile, based on the entire data set. So it's purely data driven. And when you look at the relationship between the net ultrafiltration rate and the 90-day mortality, you can see that again, that there is this on the left-hand side, this J-shaped relationship where less than 1.01 ml per kilogram per hour was associated with increased risk of death. And when you compare it with the middle group of 1.01 to 1.75, and when you compare it with the group greater than 1.75, there's a substantial increase in the risk of death when you dose weight higher than 1.75 mLs per kilogram per hour. And so when you look at the data on these 3 groups, you can see that patients who received higher ultrafiltration rate greater than 1.75 ml per kilogram per hour, they were on an average on a higher negative fluid balance. So they were 3.6 liters negative compared to only 0.4 400 mLs negative in the middle group, and then 2.3 liters positive in the less than 1.01 ml per kilogram per hour group. However, the death, you can see the mortality was 48.6% when you remove fluid at a higher rate compared to the middle group and the lower group. And this is unadjusted mortality. And now when we adjusted for other disease characteristics using this gray modeling, which looks at the varying hazard of risk of death over the 90-day period, you can see when you compare greater than 1.75 ml per kilogram per hour with the middle group of 1.01 to 1.75, there is a significantly increased risk of death, and with greater than 1.75 ml per kilogram per hour. And then when we dose it, when you look at it based on as a continuous variable, every 0.5 ml per kilogram per hour increase in the rate was associated with increased mortality. And this finding, again, was replicated in some of the other cohorts as well. And this was robust to multiple sensitivity analysis in the study. Moreover, if you look at the higher rate patients greater than 1.75 ml per kilogram per hour, these patients had a higher risk of cardiac arrhythmias and higher risk of arrhythmias that require treatment. So these are not just innocuous arrhythmias. These are arrhythmias where people had to deal with it, do shocking or some sort of an intervention to treat the arrhythmia. Furthermore, when we look at renal recovery, higher rates were associated with lower renal recovery, meaning that these patients were on dialysis for longer period of time compared to patients who received lower net ultrafiltration rate. And this was true even after we accounted for the competing risk of death in these patients, because if you die, you can't recover. So that needs to be accounted in the analysis. Furthermore, when we looked at by severity of illness, so these are Bayesian cluster analysis that we conducted based on the underlying severity of illness. And what we found was that if you have a severely ill patient who had severe metabolic acidosis, severe hemodynamic instability, on mechanical ventilation, and if you apply a higher rate to those patients, a greater than 1.75 ml per kilogram per hour, they had a 99.9% higher probability of 90-day mortality from the renal trial. Nevertheless, the middle group of 1.01 to 1.75 ml per kilogram per hour is the group that was consistently associated with lower mortality among critically ill patients. Furthermore, when you look at it by cardiovascular SOFA score, patients who had cardiovascular SOFA scores shown on the right here, a baseline cardiovascular SOFA score greater than 3, which are patients who are hemodynamically unstable and vasopressors. If you look at if we apply a higher net ultrafiltration rate on these patients, there was a significantly higher risk of death among these patients. So the emerging theme from some of these studies is that there is this J-shaped association between net ultrafiltration rate and survival, and the safest zone might be somewhere in the middle of 1.01 to 1.75, and anything lower than 1 ml per kilogram per hour might be associated with increased mortality, and anything greater than 1.75 might be associated with increased risk of organ ischemia and death. And if you look at many of the studies that have been conducted in end-stage hemodialysis population, you can see that the high ultrafiltration rates were associated with increasing evidence for organ dysfunction, organ ischemia. So this is a study that was conducted by Chris McIntyre's group that found that ultrafiltration fluid removal during hemodialysis of greater than 1 liter, the odds ratio of death was significantly higher. If you increase it by 1.5, the odds ratio went up to 11.6. And if you remove 2 liters, the odds ratio was 26. So, and furthermore, higher rates was associated with hemodynamic instability and increased risk of hypotension. Why is this? If you actually think about it, it makes sense, right? Because any form of dialysis is a form of controlled hemorrhage. So you are inducing controlled hypovolemia on these patients. And the only way the body compensates by this is to do a vascular refill. It refills from the extravascular space into the intravascular space to maintain hemodynamics. And when the fluid removal rate exceeds the refill rate, then that's where problem happens, where you develop organ ischemia and organ injury and hypotension. So this is a nice study that was conducted among hemodialysis patients, showing that the higher ultrafiltration rates are associated with decreased renal perfusion. So they conducted dialysis while the patient was undergoing CT perfusion angiography, showing that when they increased the net ultrafiltration rate, the renal perfusion actually went down. And furthermore, there was an increase in the number of myocardial segmental wall motion abnormality and stunned myocardium when the rate of fluid removal or the net ultrafiltration rate was increased in hemodialysis patient. So that brings up this question about, what is really net ultrafiltration rate from the CRRT standpoint? It is important to know this. It is the net extracorporeal fluid removal rate from the intravascular compartment of the patient per unit time. So if you think about it, it is the actual volume of extracellular fluid being removed from the patient. And it also represents the hourly difference between the patient and the machine fluid balance. And more importantly, it is not the same as a machine set fluid removal rate. So in other words, if you have a patient on CRRT and you're removing fluid at a rate of 100 ml per minute, then if the patient is getting 100 ml per hour in that same hour using IV fluids and all the other things, your dose net ultrafiltration rate is actually zero. Even though you're removing fluid, you're not removing any net fluid from that patient because you're just removing what you're actually giving in that patient. So when I mean net ultrafiltration rate, it is the net difference between what is happening in the machine and what is happening in the patient. So this is an example to illustrate this concept on how to calculate the net ultrafiltration rate during CRRT. So you have a patient who weighs, in example 1, weighs 100 kilograms. And if you are doing a CRRT fluid removal rate of 200 ml per hour, and the patient is also getting a fluid infusion of 100 ml per hour for whatever reason in that hour, TPN is going, they're getting medications, they're getting blood, etc. The net ultrafiltration rate is 200 minus 100 and is 100 ml per hour. And when you divide that by the weight, it's only 1 ml per kilogram per hour. On example 2, it's the same thing, but here you're removing fluid only at 100 ml per hour, but the patient is getting 200 ml per hour in IV fluids and other things in the same hour. Now, when you subtract 100 minus 200, you see that the patient is negative 100 ml per kilogram per hour. So what this means is that even though you're removing 100 ml an hour, the patient is becoming positive 100 mLs every hour, which means at the end of 24 hours, this patient will be 2.4 liters positive. So it's important to know what you're doing and how to dose it. And furthermore, it's important to dose it based on the weight of the patient. Because in all these observational studies, if you don't adjust for the patient body weight, then the relationship between net ultrafiltration rate and mortality goes away. So why do we need to adjust for body weight? If you actually think about it, net ultrafiltration has to be dosed like a drug, right? So when we give fluid, we say 30 ml per kilogram per hour, or 1 ml per kilogram per hour infusion. So when you remove fluid, it's the same thing. When you quantify it based on body weight, what you're essentially quantifying is the amount of stress that you're applying on the patient. So if you're removing 100 mLs per hour in a 50 kilogram patient, you are applying a stress of 2 ml per kilogram per hour. On the other hand, if you're removing 100 ml in a 100 kilogram patient, the stress is only 1 ml per kilogram per hour. So, and how the body tolerates it will vary depending upon how much they are. Think of it like a tidal volume, right? So you dose the tidal volume based on the body weight of the patient or the predicted body weight, right? Based on the measured height and so on. So that's how we should be dosing net ultrafiltration, not in an arbitrary way. So when we looked at international surveys on how we should dose and asked patients how frequently they looked at machine and patient fluid balance, only about a third of providers looked both the CRRT patient and machine fluid balance every hour. Most of them, and you could see, many patients looked at 2 hours, 4 hours, or even 20 physicians looked at 2 hours, 4 hours, or 24 hours. And nurses were the one who consistently looked at it much more frequently than the physician. So it's very critically important that we make sure that we integrate what is going on in the patient and what is going on in the machine when we dose net ultrafiltration. So this is much more complicated than how you would set tidal volume and manage a ventilated patient. There's a lot of focus on how on ventilator management and so on. But CRRT is much more complicated than ventilator because it's dynamic, and you have to look at what's going on in the patient and what's going on in the machine, especially when you're dosing fluid removal in these patients, because you could have a patient, you may be giving 100 mLs in IV fluids and TPN, but if the patient is also losing 100 mLs an hour in the chest tube or in terms of the ostomy output, the patient is already losing 100 mLs, through their drains. And on top of that, if you're applying another 100 mLs of fluid removal on CRRT, then essentially you're removing 200 mLs an hour in that patient. And that needs to be accounted into it, because otherwise you would compromise vascular refill and you would get into issues with hypotension. So we published some tools in terms of Excel spreadsheets and other things on how do we calculate and dose net ultrafiltration rate, where this is one spreadsheet where if you went and entered in your desired range of net ultrafiltration dosing and entered the infusion medications, it will tell you what to set on the CRRT machine in order to get a delivered net ultrafiltration rate of like whatever you want to deliver the patient. So using some kind of a tool to dose is really important. So what did we do in this patient, right? So the patient that I showed you before, this patient had a admission weight of 115 kilograms. The current body weight is 125 kilograms because the patient was, 10 liters, 10 kilograms fluid overloaded. The height is 159, and the IV carrier fluids, the patient was getting 70 mLs per hour and all the infusions, norepinephrine, propofol, and other infusion. So based on this, we decided to start a net ultrafiltration rate, a dose and net ultrafiltration rate of 1 to 2 ml per kilogram per hour. And this patient is getting 70 mLs per hour. So when you plug in all the numbers, right? So when we say, I want to start at 1 ml per kilogram, and you plug that based on the weight of the patient, and you include the IV fluid that is going on in the patient of 70 mLs, you get 185 mLs. So in order to give a 1 ml per kilogram per hour dosing of net ultrafiltration rate in that patient who is getting 70 mLs per hour, you need to start at 185 mLs, an hour of fluid removal rate. You can go, if you want to dose 2 ml per kilogram, you need to dose at 300 mLs per hour in order to get there. But you don't have to start right away at that rate. You could start at 0.5 ml per kilogram per hour, which would be 128 ml per hour, and then slowly increase the fluid removal rate at 0.5 ml per kilogram per hour until you get to this target fluid removal range. And that's what we did on this patient. So this is just the dosing prescription for CVVHDF, in this patient where we're dosing effluent separately, and it's primarily the pre-filter, post-filter replacement. And this is the fluid balance prescription where we start at 300 ml per hour, and we are dosing at 200 ml per hour. So we got there slowly after, when we started at 0.5 and after slowly increasing it to 0.5 ml per kilogram per hour. So that brings up an important point about should we ever use high ultrafiltration rate? And the answer is it depends upon what the circumstances is. And if you get into a situation where the patient is in severe pulmonary edema due to fluid overload, refractory hypoxemia, difficult to ventilate, who's desatting riding in front of you, you need to remove fluid at a higher rate because it's a risk-benefit ratio, right? So if you don't remove fluid rapidly to rescue the patient from hypoxemia, that patient is going to die. So it's a risk-benefit balance when you get into these emergency situations. Same way, if you have a patient with severe oliguric AKI and is, and respiratory distress, breathing 50 times a minute on a BiPAP, where, who's on the verge of getting intubated, then you need to remove fluid at a higher rate to prevent that patient from getting intubated. And in our trauma ICUs, we get a lot of patients, who undergo who have open abdomen due to damage control laparotomy, and we can close the abdomen because of severe abdominal wound edema. Under those circumstances, we have to remove fluid to facilitate the surgeon to close the abdomen. And the same thing with spontaneous breathing trials. If somebody is failing, then you have to give them a higher rate so that you can get them off the ventilator. So using the clinical judgment is really important. What I just showed you is data. When patients who don't have these emergent situations, how do we dose is what the data I actually showed you. So we are conducting a randomized clinical trial to examine the feasibility of a restrictive versus a liberal approach to net fluid removal in critically ill patients. So this trial is funded by National Institute of Health in the US. And we are studying, two different rates of net ultrafiltration rate in a stepped wedge cluster randomized trial where we are randomizing these 10 ICUs to one of the liberal or the restrictive arms of fluid removal. So all ICUs will start in the liberal arm, and then slowly one ICU over a period of time will move to, randomly, will move to the restrictive arm. So in the restrictive strategy, we are dosing net fluid removal rate at 0.5 to 1.5 ml per kilogram per hour. And in the liberal strategy, we are dosing between 2 to 5 ml per kilogram per hour. And in order to accurately dose, we are using predicted body weight. So we are not entirely sure which weight we should be using. There are problems with using actual body weight. And all of these studies were conducted using the actual body weight. But if you think about it, the actual body weight will vary based on when you remove fluid, because it varies depending on every single day when you remove fluid. Moreover, the body weight also varies because critically ill patients are hypercatabolic. So they're losing muscle mass every single day. So that weight will vary. For that reason, we are using predicted body weight to make sure that we dose, just like how we dose set tidal volumes on the ventilator, where we use predicted body weight, we're using the same thing. And we're also accounting for hourly IV fluids, and we're using an iPad or a web app to dose the net ultrafiltration rate. And so in either arms of the trial, we start at 0.5 ml per kilogram per hour and then slowly increase the rate to the target rate. So in the restrictive arm, they will be at a target rate between 0.5 to 1.5. And then in the liberal rate, they will go up to a target rate between 2 to 5. And either arms of those trials, net ultrafiltration rate can be stopped if they develop hypotension or arrhythmias or instability. And then when you restart it back, you start it really slowly, and then you try to go to the target rate. And the primary outcomes we are looking at is the mean delivered net ultrafiltration rate separation of at least 5.53 ml per kilogram per hour between the two groups to see whether there is actually a difference in the treatment arms in terms of the delivered dose of the net ultrafiltration rate. And the reason why is this important is that before going to do a large randomized clinical trial involving hundreds of thousands of patients, we want to make sure that the protocol is actually feasible. So that's why we're studying this. We are also looking at protocol deviation, and we are also looking at the recruitment rate. And you can see that this is the current trial recruitment. We've enrolled about 90 patients so far against a total of 112 patients across 2 ICUs. So we're conducting at University of Pittsburgh Medical Center and also at Mayo Clinic. And that's what we're enrolling. So in summary, I'd like to conclude by saying that 2/3 of critically ill patients with acute kidney injury requiring RRT have fluid overload. Fluid overload is associated with morbidity and mortality in multiple studies. However, we do not know what is the optimal or the best way to remove fluid in these patients. So the optimal dosing of net ultrafiltration rate remains uncertain, and both high and slow net ultrafiltration rates has risks and benefits. If you remove fluid slowly, the benefit is that the patient may tolerate it better, but on the other hand, you are increasing exposure to organ edema in that patient. So that patient may end up staying on the ventilator for 1 more day or have organ dysfunction for more days. On the other hand, if you remove fluid at a faster rate, then there's a higher risk for cardiac arrhythmias, hypotension, and so on. But that's the risk. But the benefit is that you can get them onto a negative fluid balance much quicker. So we don't know which is the right method. But having said that, we need to, until evidence is available from randomized trial, we need to, individualize net ultrafiltration dosing based on what is their hemodynamics, how severe their fluid overload is, how much is their organ dysfunction. And I would say that, from my practical experience, what I find is that slow and steady is the best approach. In other words, I typically dose between 1 to 2 ml per kilogram per hour until we get high quality evidence from randomized trials, because if you go higher, then what happens in our ICUs is that, then once the patient gets hypotensive, fluid removal gets stopped and nothing ever happens for the remaining 24 hours. And moreover, the patient gets an additional liter of fluid, which defeats the whole purpose of fluid removal. So that's why I use a slow and steady approach to net ultrafiltration, in the belief that slow and steady approach wins the race as opposed to a sprint and pause strategy where we're doing fast and then stopping and then giving more fluids and so on. So with that, I'd like to conclude and acknowledge my team members, so many of my collaborators who helped me to conduct some of these studies and to move the field forward. So with that, I'm happy to take any questions. Thank you for your patience and listening to my talk.
So thank you, Professor Dr. Murugan. So that was so, I can say comprehensive, but yes, very short and succinct. So few questions, or I can say that you have mentioned that slow and steady wins the race. So are we expecting the upcoming RCT, though it is still ongoing, is in the same line? Or
Yeah. So we're
there is-
comparing two different methods. So we are comparing two different methods here. So in the restrictive arm, we are doing 0.5 to 1.5 ml per kilogram per hour. So that's like kind of the slow and steady group. And then the liberal arm, it's 2 to 5. So like 5 mLs is like, in a 70 kilogram patient, it's like 350 mLs, sort of assuming that the patient's not getting anything. So we wanted to see, and we are collecting very detailed primary and secondary outcome data, looking at how frequently hypotension, cardiac arrhythmias, all those things are actually happening on those patients. We are collecting granular data. So we wanted to see first, is it feasible to maintain patients in the restrictive arm? That's what the question is, because although the protocol allows for rescue ultrafiltration, so you do the restrictive arm and then suddenly the patient gets fluid overloaded, you have to go up at a higher rate. But that's what we are studying, to see whether it's feasible to maintain within those groups in the trial.
Thank you. So now the discussion is open for the panelists. If you can just have some of the questions or queries or comments, Dr. Jigar, Dr. Dilson, anything from your side?
Maybe
Dr.
I can
Sridhar?
answer the questions in the chat that people have. So how to calculate weight, right? Actual, adjusted, or ideal? So that's a very good question. And we actually don't know what is the right weight to use. My own bias is that if you use the actual body weight, it is highly confounded, because think about it. You have a patient coming in with sepsis, community-acquired pneumonia to the hospital, right? And you measure a weight at the hospital admission in the emergency room. That weight is not an accurate weight, because the patient could be dehydrated, not eating or drinking or having diarrhea. So that's a lower weight. And so the patient could be deconditioned. Conversely, think about another patient who has heart failure or liver failure and who already has fluid overload. And when you measure that weight at hospital admission, even that is not an accurate weight. And then if you, every single day that the patient stays in the hospital, their weight changes. Primarily, they are hypercatabolic. They are not moving around and they're losing muscle mass every single day. So none of these, and moreover, there are measurement errors on how we measure the weight, whether the scale is accurate and so on. So for that reason, for this trial, we are actually using the predicted body weight, like how we dose, because the predicted body weight is measured based on the height of the patient, and it will remain the same for the rest of their life. So when I say 2 ml per kilogram per hour on this patient, I know exactly it will be 2 ml means that will remain the same, independent of what the actual body weight changes. So that's why we're using the predicted body weight or the ideal body weight. But essentially you could use whichever. If you're using actual body weight, then you use to measure the weight on a daily basis and then dose it accordingly. So that's what the problem is. So the next question is if the fluid removal is more than 100 ml per hour, the total UF will go up and ultrafiltration fraction also increases. How to tackle? Very good question. So one of the main determinants of filtration fraction is actually the blood flow rate. Make sure that the blood flow rate is very, very high. So in other words, like 350 to 400 mLs a minute, because if you drop the filtration rate, then you could, blood flow rate, then you could, increase the filtration fraction. The other thing is that we do a lot is we use CVVHD instead of CVVHDF. So when you do CBBHD, you're actually keeping the ultrafiltration rate lower when you do purely dialytic clearance as opposed to convective clearance. So that's another way to keep the filtration fraction low. Remember, when I say 100 ml per hour, this assumes that you're not removing patient is not getting any fluids. And in most patients, if you look at it very carefully, the patient is getting something or the other infusion going into the patient. So when you say 100 ml per hour, I assume that you're meaning a net of 100 ml per hour, like after accounting for whatever is going on in the patient. So that's why, but usually I would say when you dose between 1 to 1.5 ml per kilogram per hour, according to the predicted body weight, it's very rare that you will end up with this filtration fraction issue. So application to calculate net UF. So I think there is a paper that we published. So there's an Excel spreadsheet that you can download it was published in Intensive Care Medicine Experimental. And if you look at the supplement of the manuscript, there is actually an Excel spreadsheet that you can download and you can use it to calculate. One should use actual body weight, ideal body weight in the calculator. So that's what I mentioned. So it depends upon what your practice is. We are trying to move away from doing this actual body weight for all the issues that we just mentioned. Is there any difference between effective fluid removal of fluid to prescribed fluid removal? So is there, I don't understand your question. Any difference between effective removal of fluid to prescribed fluids?
So I think he is trying to get the idea whether it is like protocol based or like situation based. Like you are changing the.
Usually both are important. Like both are important, right? It's like asking, when do you start dialysis on a patient? Like which is the optimal time? It depends on the situation. If you have a patient who's hyperkalemic, who's severely who's an encephalopathy or severe uremia, then you have to start right away because the evidence indicates if you don't start it, they're going to have a higher mortality. So in the same way, it depends upon how bad the patient's physiology is because of the fluid overload. Under those circumstances, you would have to start right away and then you have to dose it accordingly. So it's a balance. What we are trying to study in these studies is that on an average bread and butter patient who's lying in the ICU with fluid overload, how we should dose. Nobody is saying that when you have a hypotensive patient who's also hypovolemic, you need to give fluid bolus to rescue the patient, right? So there's no argument about that. If you don't do that, we do know that there's a higher mortality. But the question that we are trying to ask is that how much fluid a sepsis patient would need in the absence of hypovolemia? That's a difficult question. So that's what we are trying to answer in some of these studies. So what is the advantage of CRRT over SLED if the blood flow is high and patient is hemodynamically unstable? So I think one of the big advantages of CRRT is that since you're continuing therapy over 24-hour period, you have a better control of volume management using CRRT than with SLED. With SLED, you're doing it only 8 hours or 9 hours, whatever time that you're doing, and you have to remove all that fluid within that time span. Whereas in a CRRT, you are actually doing it over 24 hours. And there's good data from the PICOD study showing that when you compare IHT versus CRRT, the volume control is much better with CRRT as opposed to IHT because you're doing it on a 24-hour basis. So that's the only difference. I don't think that the blood flow really matters because if you think about it, if you're pulling blood at a rate of 350 or 400 mLs a minute from a patient, at that instantaneous moment, 400 mLs a minute is going back into the patient also, right? So it's not like you're keeping the patient 400 mLs negative every minute. That 400 ml is going back into the patient unless you remove fluid from that patient. So there's a big myth in the literature thinking that if I increase the blood flow rate, the patient will get hypotensive. That's absolutely not true. Because at any given time, whatever you're pulling in is actually going back into the patient. So it's not the blood flow rate that causes the thing. It is the rate at which you remove fluid, or there may be other reasons, like, the patient has a low oncotic pressure, or their tonicity is low, or they're having a higher cytokine release, and so on, that contributes to hypotension as opposed to just the blood flow rate. Apart from fluid infused, what other factors affect the net fluid removal rate, right? So I talked about some of the other fluid losses, right? So if you have, I just showed the example of IV fluid that the patient is receiving because we have a direct control over it. But you could have a patient who's having high fever and having insensible fluid losses. You could have a patient who is having a lot of diarrhea in the ICU and losing a lot of volume. All of those need to be accounted in calculating. And that is why an Excel spreadsheet or some kind of a decision support tool that would help to calculate it would be important. So you can also, the patient is also getting enteral nutrition of 100 mLs every hour going into the tube feeds. You could include that into the net ultrafiltration calculation. So it becomes very complicated when you have a lot of volume, but this is where a spreadsheet will help you to dose it more predominantly. But the current approach to dosing ultrafiltration, where we don't even think about it, all these things, so we just say 100 ml, 150 ml is not the right approach, because that 100 ml could removal of fluid removal during dialysis could mean 5 ml per kilogram per hour of net UF in a patient, or it could be like 0 ml per kilogram per hour in of net fluid removal in a given patient. So that's why it's important to dose it that way. What's the difference between CVVH-DF? Well, that's a different thing, right? CVVH-DF is hemodiafiltration. It's both convective and diffusive clearance. Whereas CVVH, F is basically continuous veno-venous hemofiltration. It's only convective clearance. High flow can cause arrhythmias. It's possible. It can cause. But remember, there are a lot of things that happen. So during dialysis, what the studies actually show is that if you take a patient and you put them on dialysis, even though you may not be removing any fluid, there's organ ischemia happening. Why is that happening? It's very poorly understood. And blood pressure and high ultrafiltration rate is only part of the story. I think the moment you take a patient and put them on an artificial circuit, you're doing a lot of things. You're changing solute concentration, you're changing electrolyte concentration. There is cytokine release happening at the patient level. There is also, when you pass the red cells through a filter, there is RBC shear and stress applied to the RBCs, right? So when you say, I want to remove fluid at 300 ml, the volumetric pump on the CRRT machine applies that suction of minus 300 millimeters of mercury on that fiber to pull that fluid off of that off that fiber. So it's very much likely there's a RBC dysfunction that's happening that might be contributing to, decrease oxygen delivery at the tissue level. And the reason why I say that is that the organ dysfunction occurs even in children. If you take pediatric population who have, who go on dialysis, end-stage renal disease, who don't have any coronary disease or any vascular disease, the same thing happens. There's myocardial dysfunction, there's decreased organ perfusion, despite normal organ blood flow. People have done MRI scans on these patients, looking at myocardial perfusion during dialysis, and show that the perfusion itself is actually okay, but there's myocardial wall dysfunction that's actually happening. So there's an organ dysfunction independent of whether you remove fluid or not, whether you remove that's actually happening just because by the fact that you put them on dialysis. On top of that, if you remove fluid at a higher fluid removal rate, you're going to issues with more severe ischemia and ischemic organ injury.
Thank you, Professor Dr. Murugan. I know the number of questions again prove the complicated nature of the CRRT basics to understand for the attendees as well as the trainees. So Dr. Murugan is in our WhatsApp group, official Nephro Critical Care Society. So if any question still is there, so definitely please share with us. We would be definitely trying to get some answers from Professor Dr. Murugan. So in the interest of time, if any of our panelists have any query, or else we will be thanking again Professor Dr. Murugan for giving his valuable time and discussing this very important topic, that is volume management in acute kidney injury patients.
Dr.
My pleasure.
There is a question.
Yeah, Dr. Jigar, yeah, welcome. Yeah.
So, Dr. Agan, do you have any experience related to bioimpedance analysis in ICU patients for the fluid removal?
Yeah, I haven't used myself personally, but in the studies that I've looked at, it's not good in terms of quantifying what the intravascular volume status is my understanding. And so and a few studies that I've looked at really did not change outcomes, or it's not a measure. One of the big problems that we have is that we are not able to measure the circulating intravascular volume, right? Although, pulse pressure variation, stroke volume variation, all those things are there. They're just a measure of preload responsiveness. They are not measuring actually the intravascular volume status. So that's where the problem is. And these tools have not been used to validate to remove fluid removal. You can assess how much the patient is fluid overloaded using bioimpedance, but it's never been used to guide fluid removal, or at least I've never seen a randomized trial using bioimpedance showing that there's a better outcome with bioimpedance-based fluid removal.
In conventional hemodialysis, what we are using this bioimpedance analysis, it is helping us to judge the dry weight. Obviously, there are multiple parameters otherwise that also to be taken in care. But right now, what we are doing is one prospective multi-center study for this. The data with us is about for a year. And what we are able to get is it helps us to redefine the dry weight. Obviously,
Sure.
it is not the sole parameter to be taken care, but obviously it helps in that way. So I think in ICU patients where I think you are doing this study, but there would be multiple other factors like fluid removal rate in a septic patient, or on the contrary, acute cardiorenal patient. Both patients behave differently as far as the fluid removal part is there. So in that case, this fluid removal part, what you mentioned that from liberal to restrictive strategy, how it will work over a period of time, because this etiology are different, and by that way, the result differs.
Yeah, good question. So one of the things is that if you remember, if you remove fluid really slowly and continued for a longer period of time, you will get to that goal of where you want to keep the patient on, right? If you want to remove the overall, let's say, for example, the patient is 5 liters fluid overloaded, and your goal is to get all that 5 liters out. I'm just making this up as an example. If you remove fluid removal at a slower rate, you will be able to get to that 5 liters over a period of maybe 1 or 2 days. Whereas if you remove fluid at a faster rate, you will be able to get to it at a much shorter. But the price that you're paying for that is increased organ ischemia, increased organ injury, ischemic organ injury, and so on. So that is why I think it's a balance between, it's not just the fluid alone, it's also be able to provide it safely, right? So think about it, because this is something that's not happening to the patient. It is something that we are doing it to the patient. So if we think of it like setting a high tidal volume, when you set a high tidal volume, there's ventilator-induced lung injury that we are actually causing on the patient by, ventilating at a higher tidal volume ventilation. So that is why it's important to make sure that we control the rate as much as possible, but you will eventually get there. Like, it may take a little bit longer time, but to getting there safely is more important than getting there quickly and then having all these problems. Is my view. So
Okay, thank you.
Okay, thank you, sir. And definitely we'll be always thinking to have your ideas also in between, like in case we are having few more doubts as well as queries from our attendees. Yeah. So thank you very much. And with this, we come to end of the first talk. And now I would
thank you.
request Professor Dr. Safa Helal from Egypt. And I have already introduced her that she needs no introduction. She is very much academic oriented and always tries to take the level of academics in this part of the world to the next level. So welcome, Professor Dr. Safa Helal, for your talk on peripartum AKI. You can share your screen, ma'am.
Yeah. Okay. Thank you, Dr. Tabas, for the nice invitation. Thank you for the nice introduction. I am pleased to attend the lecture of Dr. Morgan. It was very informative and highly distinguished lecture. Me, Safa Hilal, Professor of Anesthesia, ICU and Pain Management, Menofia University, Egypt. I am the founder and the general manager of Egyptian Society of Anesthesiology and Acute Care. My topic is Peripartum Kidney Injury, Anesthesiologist Perspectives. So the outlines are introduction, overview of the importance of kidney health during pregnancy, causes of kidney injury in pregnant women, clinical picture of kidney injury, maternal and fetal complication, prevention, conclusion, and references. Kidney injury during pregnancy is relatively rare, but can pose a significant risk to both the mother and the developing fetus. This condition encompasses a spectrum of disorder ranging from mild impairment to severe dysfunction. Understanding the etiology, risk factor, and management of kidney injury in pregnant women is crucial for healthcare professionals to ensure timely intervention and optimize outcome for both mother and infant. So we have renal physiological and anatomical changes during pregnancy. As the urinary tract demonstrates remarkable alteration in both anatomy and physiology, understanding of these changes is crucial in evaluating renal disease in pregnant women. As regards the anatomical changes, the size of the kidney increased by 1 to 1.5 centimeter in length because hypertrophy of renal vasculature and interstitial space expansion. Pregnant women develop physiological hydronephrosis as the gravid uterus causes partial extrinsic mechanical obstruction of the urinary tract. The progesterone hormone causes smooth muscle relaxation, while prostaglandin E2 inhibits ureteric peristalsis. This will lead to urinary stasis, increase the incidence of bacterial infection and urinary tract infection, which persist to 12 weeks postpartum before returning to the normal pregnancy state. As regards the physiological changes, after conception, the glomerular filtration rate increased continuously, so hyperfiltration state occur, increase in uric acid clearance, increase excretion of calcium, glycosuria, increase filtration of amino acids, increase creatinine clearance, lower the blood urea nitrogen level, serum creatinine, considerable fall to pregnancy range of 0.4 to 0.8 milligram per deciliter, hence a serum creatinine level of 1 milligram per deciliter, so within a normal limit in the general population, signifies renal impairment in the pregnant population, and the prompt further investigation is needed. The importance of kidney health during pregnancy. Number one, for proper fetal development, as proper kidney function ensure the elimination of waste product, creating a favorable environment for fetal growth and development. Also, for proper maternal health, healthy kidney help regulate blood pressure and the fluid balance, which are essential for the mother's overall well-being during pregnancy. Prevention of complication as preterm birth, low birth weight, and maternal morbidity and mortality. Detection of the underlying condition. Pregnancy can exacerbate pre-existing kidney condition like chronic kidney disease, and the medication safety, of course. Many medications commonly used during pregnancy are metabolized and excreted by the kidney. Overall, prioritizing the kidney health during pregnancy is essential for ensuring the well-being of both mother and the fetus. So kidney injury in pregnant women can be caused by various factors. The main differential diagnoses include preeclampsia, urinary tract infection, acute tubular necrosis, HELLP syndrome, acute fatty liver of pregnancy, chronic kidney disease, obstructive uropathy, gestational diabetes, drug-induced nephrotoxicity, and thrombotic microangiopathy. This condition requires careful evaluation and management by healthcare professionals to ensure the best outcome for both the mother and the baby. Diagnosis of kidney injury, firstly, by medical history, physical examination, laboratory test, imaging studies, and finally biopsy if other tests are inconclusive. Physical examination for high blood pressure, abnormal urine output, edema, laboratory test, creatinine, blood urea nitrogen, electrolyte, urine test to check for proteinuria and hematuria. Dr. Tabaz, please. Dr. Tabaz.
Yeah, hello. Yes, please.
The voice is good. Everything is okay.
Yeah. All good, all good. Please continue.
Thank you. Imaging status like ultrasound, MRI, CT, and biopsy if other tests are inconclusive. The risk factor associated with pre-acute kidney injury in pregnant women include intrapartum infection. This constitutes 48% of patients, preeclampsia 26% of patients, hemorrhage 25% of cases, and of course 15% of women with acute kidney injury had no identifiable cause. Maybe autoimmune, maybe fatty liver, intrapartum hepatic cholestasis, or E. coli sepsis. But of course, the pregnant woman should have risk factors, maybe obesity, hypertension, or diabetes mellitus. The major causes of acute kidney injury, ureteric injury, post-arrest, dehydration, sickle cell crisis, infection, thromboembolic, DIC, HELP, postpartum hemorrhage, drugs, and common hemorrhage. So now, there is a relation, of course, is a relation between acute kidney injury and pregnancy. This paper was published in 2015 by Munchiai, and the introduction acts that acute kidney injury was defined as an increase in serum creatinine within 2 to 7 days or oliguria. It affects 10 to 20% of hospitalized adults, and it is associated with an increased risk of chronic kidney disease and the further complication. The development of acute kidney injury in pregnancy termed pregnancy-related acute kidney injury. It is not rare. It occurring between 6 to 55% of cases, and this condition is one of the most common causes of acute kidney injury and contributing nearly 20 to 40% of all cases, and the mortality rate carry high risk for the mother and the fetus. So how to diagnose the acute kidney injury in pregnant women, new paradigm? And this is paper published in 2020 by Sharat Thono-Brayon, and he speak about the risk factor or the stages of acute kidney injury, where stage 1, when serum creatinine ranges from 1.5 to 1.9, and the urine output less than 0.5 ml per kg per hour, and this for 6 to 12 hours. Stage 2, when the serum creatinine range between 2 to 2.9, and also the urine output is less than 0.5 ml per kg for more than or equal 12 hours. Stage 3, when creat reaches 3 times the baseline, more than or equal 4, and the urine output less than 0.3 ml per kg per hour for more than or equal 24-hour anuria. Risk factor for acute kidney injury. We have modifiable risk factor and non-modifiable. As regards the non-modifiable, of course, will be chronic kidney disease, chronic liver disease, congestive heart failure, diabetes mellitus, older age, and peripheral vascular disease or autoimmune disease generally. Modifiable factor to lessen the incidence of acute kidney injury: anemia, blood transfusion, hypertension, hypercholesteremia, hypoalbuminemia, infection and sepsis, mechanical ventilation, nephrotoxic agent, use of vasopressor and inotrope, high-risk surgery, emergency surgery, hemodynamic instability, use of intra-aortic balloon pump, longer time in cardiopulmonary bypass. Of course, we have to identify the patient at risk to develop acute kidney injury. This may be the patient demographic data as the age, the sex, the comorbidity, use of clinical decision support by electronic-based alert system, maintain eovolemia, avoid nephrotoxic medication, judges use of contrast studies during investigation, avoid hypotension, renal function test, specific clinical scenarios, patient undergoing a procedure need IV contrast media, traumatic and non-traumatic rhabdomyolysis. So we come to the starting point again. Diagnosis of kidney injury in pregnant women is particularly challenging due to the normal physiological changes that occur during pregnancy. Consider the health and the safety of both the mother and the developing fetus. Therefore, close monitoring and collaboration between obstetrician, nephrologists are essential for proper diagnosis and management. The management of pre-acute kidney injury requires a lot of resources and involves multidisciplinary team of medical specialists. Role of anesthesiologists are early detection, prompt intervention, should be early, timely, and correctly. Hemodynamic stabilization for the mother and the fetus by close monitoring, treatment of the underlying condition, monitor fluid, blood pressure, and medication. Hemodynamic status can be optimized by adequate fluid replacement to correct volume deficit, electrolyte correction, control of bleeding, and the blood transfusion when necessary. Blood pressure should also be controlled in hypertensive pregnant women. This could minimize the progression of further kidney damage. Monitoring of maternal blood pressure, renal function test, and urine protein examination are necessary and should be performed frequently too early to detect any abnormality. Fetal monitoring can be done by several methods. Regular fetal monitoring is helpful in early detection of fetal distress. The proper use of antibiotic according to the culture and sensitivity is essential in cases of infection. Fluid and electrolyte repletion is warranted in those presented with hyperemesis gravidera. Blood transfusion should be rendered to those with massive obstetric hemorrhage. Management of preeclampsia is targeted for blood pressure control, prevention of seizure, and timely delivery. In thrombomicroangiopathy, treatment with plasmapheresis is proper and efficient to increase maternal survival. In amniotic fluid embolism correction of coagulopathy with blood component, hypoglycemic prevention with adequate glucose administration, and hepatic encephalopathy treatment with a low protein diet and oral lactulose are all essential to stabilize the mother. Acute kidney injury. We have a paper published in 2020 this about the kidney disease improving global outcome. Acute kidney injury in pregnancy remains an important worldwide determinant of maternal and fetal morbidity and mortality. Proposed to contribute to higher rate of pre-acute kidney injury include advanced maternal age, obesity, comorbidity such as hypertension, diabetes mellitus, and chronic kidney disease, and also advances in detection and the recognition, means delayed diagnosis, of course, will worsen the condition. Furthermore, acute kidney injury in women of childbearing age has recently been recognized to be associated with the risk of pregnancy complication, including preeclampsia. Thus, accurate identification of pre-acute kidney injury to prevent immediate and long-term health complication is likely warranted to reduce the severity of adverse outcome and economic burden. Of course, the maternal-fetal complication include preterm birth with its sequelae as respiratory distress syndrome and the developmental delay, low birth weight, many experiences health issue both in short and the long term, hypertensive disorder, maternal morbidity and mortality due to pulmonary edema, electrolyte imbalance, cardiovascular complication, maternal mortality, and of course, lastly, fetal demise. So after renal transplant, we have, the patient get pregnant. We have paper published in 2023. There are now more than 14,000 reported cases of pregnancy after kidney transplantation. Kidney transplant recipients who become pregnant are at high risk of obstetrical morbidity, including preeclampsia, preterm birth, and cesarean delivery. They are transplant may be from deceased organs or from living donor. They found that current data showed that the patient with living donor transplant have improved 5-year graft survival compared with patient with deceased donor transplant, with rate 80 to 76 in pregnancy. There is a lack of data on donor graft type and outcome, but for further studies will clarify this point. And this study concluded that pregnancy after a deceased donor kidney transplant was associated with higher risk of short and long-term graft loss compared with pregnancy after a living donor kidney transplant. In general, we should continue to encourage living-related and living-unrelated kidney donation. Kidney transplant recipient with a deceased donor graft should receive early preconception counseling, individualized risk-based intrapartum surveillance, and close postpartum follow-up by multidisciplinary obstetric and transplant team. Now we have the window to see the artificial intelligence. Does the artificial intelligence have a role in diagnosis and management of acute kidney injury in pregnant patients? What do you think? What do you think, Tabaz?
Yeah, definitely. I think everywhere artificial intelligence is getting entry. So
me and you are great friends for artificial intelligence. So now we will see that we have a paper published in 2024, the concept of progressive immunoglobulin refers to the gradual development and maturation of immunoglobulin A nephropathy is an acknowledged etiology of renal failure. It has been postulated that the existence of a function that establishes a relationship between clinical and biological parameters such as age, sex, blood pressure, proteinuria, serum creatinine level, and antihypertensive treatment at the time of immunoglobulin nephropathy diagnosis and the likelihood of developing progressive immunoglobulin nephropathy. So the researchers devised and executed the development with the purposes of approximating the after-mentioned function. Artificial intelligence model have been applied for the various purposes, including prediction, the rate of decline in glomerular filtration rate in individual with autosomal dominant polycystic kidney disease, enhancing anemia management in hemodialysis patients, estimating an appropriate duration of dialysis to achieve the desired level of urea removal, determining the optimal dry weight in patients undergoing hemodialysis, and identifying the specific pathogen responsible for bacterial infection. So artificial intelligence has the ability to improve diagnosis accuracy, personalized treatment plans, and reduce healthcare costs. Overall, it is considered that the artificial intelligence has the potential to greatly improve healthcare outcome, but it is important to address ethical concern and establish clear guidelines for its development and implementation. So we are the era also of climate changes and many international conferences about does it influence the peripartum kidney? We will see. Also in January 2024, we have published a paper published about the climate changes and its influence in nephron mass. And this wrote that treating food, this high climate or climate changes influence food supplies and increase risk of wildfires, floods, and associated with increased risk of infectious disease. Air pollution contribute to climate change, but has also been associated directly with the risk of acute kidney injury, chronic kidney injury, and the transplant dysfunction. The impact of climate change on adult kidney function is therefore becoming increasingly clear. Climate change disproportionately impacts children and may directly or indirectly impact kidney function. This is known about the impact of climate change on pregnancy. Normal pregnancies associated with impaired thermoregulation and immune response. Pregnant women are more sensitive to the temperature, fluid, infection challenges posed by climate change, which may impact fetal development. The potential impact of climate change on development of the fetal kidney and the long-term risk of kidney disease has seldom been investigated. This paradigm termed the developmental programming was suggested by Parker et al., who reported that adults with low birth weight had a greater risk of premature cardiac disease compared with those with normal birth weight. So nephron number increase with increasing birth weight and gestational age. Nephron number does not increase after birth. Therefore, gestational exposure impact at individual reservoir of nephron for life. As nephron number cannot be routinely counted in living human, the best surrogate markers for programmed risk of kidney disease remain low birth weight, small for death, and low birth weight babes. Multiple molecular mediators are involved in kidney programming, such as gene expression alteration, apoptosis modulation, accelerated syncytial, and gender effect, all of which may be susceptible to gestational exposure. Furthermore, diabetes, cardiovascular, and preeclampsia risk are also associated with developmental programming. There is chronic kidney disease described in the individual with extremely low birth weight or gestational ages, but not all individuals born too small or too early develop hypertension or kidney disease. So the climate-sensitive diseases, climate-sensitive infection, and the food security, but may risk overlap. Additional programming effect of air pollution, environmental toxins are also should be considered. So what are our recommendations? Firstly, preconception counseling. Women with a history of kidney disease should receive preconception counseling to optimize their health before pregnancy. Medication adjustment, lifestyle changes, reduced salt intake, and regular exercise, counseling on potential risk during pregnancy, regular monitoring. These patients should undergo regular clinical and laboratory monitoring to help to detect any worsening of kidney function or other complications. So regular kidney function, blood pressure monitoring, urine protein level, monitor for appropriate fetal growth and development. Multidisciplinary care, it may be necessary to consult or refer to maternal-fetal medicine, nephrologist, or other specialists for further evaluation and management. Nutritional support. Patient may benefit from nutritional support. Ensure patient is receiving adequate nutrients. Additional counseling on avoidance of nephrotoxic agent. Minimizes stress on the kidney. This may involve working with a dietitian to develop a personalized meal plan. Medication management, careful consideration must be given to the use of medication during pregnancy, Some medication commonly used to treat kidney disease are not safe during pregnancy as the ACE inhibitors. Delivery planning. The timing and the method of delivery should be carefully planned to minimize risk to both the mother and the baby. In some cases, early delivery may be recommended to protect the mother's health. In other cases, cesarean section may be the safer method. Postpartum follow-up. Close monitoring should continue after delivery and may involve ongoing medication management and follow-up within healthcare providers. Continue to assess kidney function and ensure any complications are promptly addressed. Thank you.
Yeah, so thank you, Professor Dr. Safa, for this illustrative discussion as well as the talk. So the discussion, the forum is now open for any panels if want to share any of the questions or queries. Dr. Sanant, Dr. Jigar. So if we have any questions from the attendees, we can
No, we don't have any
discuss.
question.
Yeah, okay. So Dr. Safa has explained it very nicely, and we are closing the second discussion here, the talk. Thank you, Professor Dr. Safa.